Hello all. So this is our cardiovascular system part 2 and this is a part of our 90-day universal pre-final mastery program. So in this program we will be rapidly revising all the important questions which are frequently asked in the exam, and volatile facts we'll be revising multiple times, and high yield topics also. So these are a few long essay questions, and mostly in short essay we will be covering rheumatic heart disease in detail. In Auricle, we have recorded classes, live classes, practical sessions, exam modules, and also hard copy books. Flexible learning is facilitated in our foundational classes. Live classes, we have in-depth coverage of each and every important topic along with interactive learning. There is an express exam module in which we cover all the last 10 years question along with answer writing skills and how to present your answer in an efficient way to score maximum marks. And this is just done in a span of 20 hours. There is a one-to-one doubt clearing session where there is a safe learning environment, so you don't have to worry about your doubts and just ask your questions and get your answers cleared. Hard copy note sets are also available. There are question banks with 3 levels of expertise. There is a beginner level and PG level, and also an FMs for FMGs. It will be useful. Practical sessions are there with hands-on experience, expert guidance, and this will help you excel in practical exams. So these are a few subscription plans which are available. You can go to the website and then look up for the subscription plans which suits you best. So this is the cardiovascular pathology which we are going to discuss. First of all, this is a long essay question and a clinical case. This is a very important clinical case. You've been asked the same clinical case with the same diagnosis and same questions in multiple forms. So we'll be discussing how to approach this question. For this is a 45-year-old man. He was rushed to the hospital following sudden onset crushing substernal chest pain. So this is one of the important signs and important factors to know you have an myocardial infarction. So substernal chest pain relating to the arms. And despite advanced life support, his condition was marked by intractable cardiogenic shock, and he died 4 days later. So autopsy revealed a large transmural anterolateral area of coagulative necrosis. So in this question, you have several clues here. The first clue is substernal chest pain. Substernal pain. When you are given substernal pain or pain radiating to the arms, okay, profuse sweating. So these are clues that you are dealing with probably a case of myocardial infarction. And one more clue which you can be given is an ECG clue. Okay, an ECG clue. So what would you see in an ECG? When you have a case of myocardial infarction, you will see an ST segment elevation along with a T wave inversion. This is the most common finding. You can see several findings, but always remember you see an ST segment elevation. So this is P, and you have a QRS in ECG, and then you have a T. Okay, so this is the normal ECG. Okay, you will be learning this anyway in your medicine and in your further classes, but just to have an idea of what this ST segment is, this is P, QRS, and when this S transforms into T, you have something like this instead of a straight line. So this is the ST segment elevation which you see in your ECG in myocardial infarction. And as this patient autopsy has been performed, you can see large transmural anterolateral area of coagulative necrosis. So coagulative necrosis is also a clue in this case in particular, that we are dealing with a myocardial infarction, because whenever there is an infarction, there is going to be cut off in blood supply and the organ is going to be necrosed. As we know that if there is cut off in blood supply, eventually what will happen is irreversible cell injury, and irreversible cell injury will lead to necrosis. So that is what is happening in this case also. Okay, so that is the case of coagulative necrosis. So now we know what is the diagnosis and what are the clues which point towards the diagnosis. Always when you write a diagnosis, okay, mention that this is an acute myocardial infarction and what are the clues which led you to this diagnosis. So in this case, we have substernal pain and coagulative necrosis and autopsy, which led to this, and also cardiogenic shock, which is a complication of myocardial infarction. So these are the clues which led to the diagnosis of myocardial infarction in this case. Second question is, what are the microscopic findings in this case? So always when you are going to write microscopic findings, try to write both gross features as well as microscopic features. Remember, the first 30 minutes, 0 to half hour, is reversible injury. So within this time, if the blood supply is restored, probably the myocardium may return to normal. So that is what reversible injury means. So if this does not happen in the first 30 minutes, what will happen? Irreversible injury is going to happen. So what will happen in the first half to 4 hours? There will be no gross findings. The first gross finding will occur on at the time of 4 hours. And the first microscopic finding is going to occur at 4 hours. So what is the first microscopic finding? Usually it is waviness of fibers at the border. So myocardial fibers will be wavy in appearance. That is the first microscopic finding which is going to occur. At 4 to 12 hours, what will you see? You will see dark mottling. Okay, and then early coagulative necrosis. Coagulative necrosis usually starts early. So remember it in this order. First, you will have dark mottling in your gross, and then it will change into a mottling with yellow tan infarct in the center. You will have an yellow tan infarct in the center, which will surround the dark mottled area. And then eventually what you're going to have is you're going to have a large yellow tan infarct in the center, okay? Center yellow tan softening surrounded by a hyperemic border. You just have a single border which is hyperemic. So this will happen. This will happen. This dark mottling will happen 4 to 12 hours, meaning up to 24 hours it can last. So 1 to 3 days you're going to have a center with yellow color and then hyperemic border with a larger yellow color, which will be happening around 3 to 7 days. And then what will happen? This margins yellow tan soft, maximum you will have yellow tan areas alone when it transitions to 7 to 10 days. Okay, so after this hyperemic border will slightly depress. So this will happen around 7 to 10 days. And then this will transition into red and gray color. Okay. And then finally, around 2 to 8 weeks, you will start having what is known as scar formation or fibrosis. And more than 2 months, you're going to have a complete scar. So always remember this diagram, and you can even draw this diagram. First, you will have a dark mottling, and then this dark mottling will slowly reduce and yellow tan will take over time. Similarly, in microscopy, you can see, of course, there is coagulative necrosis early, and then little by little, the first inflammatory cell which is going to come is the neutrophil. Okay, first what will you see is the neutrophil, because neutrophil is the acute inflammatory cell which comes in. And then by 3 to 7 days, which cells are going to come in? The macrophages are going to come in. Macrophages will come in, followed by fibroblasts, which will form collagen around 10 days. So around 10 days, you will have fibroblasts, which are forming collagen and granulation tissue. So fibrous scar will be formed around 2 to 8 weeks, and more than 2 months, fully formed scar will, dense collagenous scar will be formed. So this is what you have to remember. This is a very tedious table, very long table, but it can be concised with if you know the concepts. So what are the risk factors? This is the third question, risk factor. What are the risk factors? We have hypertension, hyperlipidemia, we have diabetes, smoking, obesity. So all risk factors which will lead to atherosclerosis are going to be risk factors of myocardial infarction, because atherosclerosis is going to eventually lead into myocardial infarction. So remember the risk factors of atherosclerosis. Every risk factor of atherosclerosis will eventually be risk factors of myocardial infarction also. What are the complications of acute myocardial infarction? Try to break down the complications of myocardial infarction into early complication, okay, and late complications. So in early complication, you will have everything related to the rhythm of the heart. So you're going to have arrhythmias which affect the rhythm of the heart, okay, and the 3 to 7 day complication, you're going to have everything which is related to rupture. All rupture. You have papillary muscle rupture, ventricular septal rupture, free wall rupture. So any rupture is going to happen within 3 to 7 days. And late complication, only one thing which you have to remember, which happens more than 7 days, is the pericarditis, which is Dressler's syndrome. And this pericarditis is not an infectious pericarditis. Remember, this is an autoimmune pericarditis. It is known as Dressler's syndrome. So this is an important finding. So 3 things: anything related to the rhythm, arrhythmia, cardiogenic shock, emboli. Emboli can also happen within 3 days. So arrhythmias, cardiogenic shock and stroke, any kind of rupture will happen within 3 to 7 days. And late complication, only one, which is post-MI pericarditis, which is also known as Dressler's syndrome, and it is an autoimmune condition. These are the complications of MI. So we have discussed everything. So you can actually break down your answers in this way so that the presentation also is very good. Next is a short essay question about rheumatic heart disease. So first of all, what is rheumatic heart disease? You have to know the idiopathogenesis of rheumatic heart disease. This is an immune-mediated inflammatory disease which is caused by group A streptococcal pharyngitis. Okay. Group A, it is also a beta hemolytic streptococcus. You will be reading about these alpha and beta hemolytic streptococcus more in your microbiology. So this is a beta hemolytic streptococcus which causes pharyngitis. What is the mechanism by which it attacks the heart? So this is something which causes pharyngitis. Like pharyngitis is an upper respiratory tract infection. So what does it have to do with the heart? There is a mechanism which is known as molecular mimicry. Okay, what happens is our heart has a protein. This is our heart. And there are proteins present in the myocardium, even the endocardium and the pericardium, which are M proteins. Okay. Bacterial M proteins and host tissue. So what happens? This is not the M protein which is present in the heart. What happens is the bacterial M protein is what is the virulence factor. Okay, bacterial M protein is the virulence factor of this beta hemolytic streptococcus. So what will happen is our heart is going to have myocardial tissue, endocardial tissue, and pericardial tissue, right? So antibodies are going to be produced against this M protein, which is the virulence factor. Okay, but what happens is these antibodies, we know that antibodies are very specific towards a particular antigen. In this case, the M protein, because we know in our immunity, we must have read that there are antigen-specific antibodies which are produced. So these are very specific to M proteins, and these will be produced to attack the beta hemolytic streptococci. But incidentally, what happens? This M protein structure resembles our molecular structure which is present in the heart. So the antibody gets confused and it is going to attack the heart cells, resulting in carditis. So this mechanism is known as molecular mimicry. Because The M protein molecule and the myocardial cells, they mimic each other and antibodies are getting confused. Instead of attacking the M protein, they are coming and attacking the heart cells, resulting in carditis. So this is what happens. This is the molecular mimicry. Morphology, pancarditis. So what is pancarditis? Pancarditis is when the carditis involves the myocardial muscles, myocardium, okay, the endocardium, as well as the pericardium. So this disease involves pancarditis. All parts of the heart are involved, including the myocardium, endocardium, as well as the pericardium. So this is what is known as pancarditis, inflammation of endocardium, myocardium, as well as the pericardium. What are the other morphologic features which can be seen? We have something known as Aschoff's bodies. What are Aschoff's bodies? Aschoff's bodies are nothing but a collection of inflammatory cells in between the myocardial cells. So this is a myocardial muscle, and this is another muscle. So in between two muscles, we have collection of cells, and most predominantly these cells are nothing but macrophages and even lymphocytes can be seen. So this whole structure is known as an Aschoff body. Okay, Aschoff body is nothing but a collection of inflammatory cells in between two myocardial cells is an Aschoff body. And another thing, so these are granulomatous nodules because we know granulomas have macrophages as well as lymphocytes. So these can also be called as granulomatous nodules. There are another types of cells which are known as anti-Schopf cells. Anti-Schopf cells look something like this. So these are anti-Schopf cells. What are these anti-Schopf cells? You can see these cells have nucleus which resemble a caterpillar. Okay, so these are these anti-Schopf cells which resemble the caterpillar, and these are very characteristic of rheumatic heart disease. So these are the two important named findings which you have to remember, and Aschoff bodies and anti-Schopf cells. Apart from that, we have valve involvement also. As I said, there is pancarditis, so it does not spare even the valves. So we have the tricuspid valve here and the mitral valve here. So it's going to cause valve involvement also by causing fibrinoid necrosis, because ultimately this is a autoimmune condition and it will affect the blood vessels also. There are vegetations also. Okay, we know what kind of vegetations are caused by this. There is a special kind of vegetation. We know there is a valve here, and these vegetations are present along the lines of closure. These are very small vegetations which are seen in rheumatic heart disease, and these are present along the line of closure of the valve. So this is a very characteristic vegetation which is seen in rheumatic heart disease. And thickening leading to stenosis or regurgitation can also be identified. So these are the few features which you have to remember of rheumatic heart disease. Now, specifically rheumatic carditis, we've already discussed most of it. Rheumatic carditis is going to be what kind of carditis? It's a pancarditis involving endocardium, myocardium, and the pericardium. Okay, so we know in histopathology what we are going to see. We're going to see Aschoff's bodies, which are aggregation of macrophages and lymphocytes in between two myocardial cells, and anti-Schopf cells in which the nucleus resembles a caterpillar. So these are the two characteristic findings which you can see. Also, we know endocarditis involves the valves causing vegetations which are present along the lines of closure. When we are discussing vegetations, we have to discuss other types of vegetations also. So what are the other types of vegetations we see? Heart valves. So first, we have already discussed the vegetations of rheumatic heart disease, which are present in the wall and which are present along the line of closure, and these vegetations are very small vegetations. Second type of vegetations which are very common are present in infective endocarditis. So what are the type of vegetation present in infective endocarditis? Infective endocarditis vegetations are going to be irregular in size and they're going to be destructive. So they will destruct the heart wall. Okay. Irregular, destructive, and they're going to be bacteria present because this is infective. So this is a non-sterile vegetation. You won't have any sterile component. So this is non-sterile. You're going to see bacteria there. Rheumatic heart disease, even though it is caused by streptococcus, these vegetations will be sterile because this is not caused by an infection per se, but this is an antibody-mediated injury caused by molecular mimicry. So rheumatic heart disease vegetations are going to be sterile vegetations. Then we have something which is known as non-bacterial thrombotic endocarditis. So interestingly, even this way, these vegetations are along the lines of closure, but these are bigger in size when compared to our rheumatic heart disease vegetation. So these are non-bacterial thrombotic endocarditis. What are the conditions causing non-bacterial thrombotic endocarditis? We have any carcinoma, like carcinoma of stomach or carcinoma of pancreas may cause non-bacterial thrombotic endocarditis. The last one is Libman sac endocarditis. This is a very unique type of vegetation which will usually be present on both sides of the wall. Okay, forward and backward. You will see both sides of the wall vegetation. So this is very unique on both sides of the wall. And in which condition do you usually see Libman sac endocarditis? You will see it in SL. Okay, systemic lupus erythematosus. So these are the 4 types of common vegetations which you have to remember. And here we can see in rheumatic heart disease, vegetations are on the wall leaflets and along the lines of closure. Yes, and we can see fibrosis and wall deformity. So, yes, this is just an overview of pathophysiology. Streptococcal infection is coming in, and about after 2 to 3 weeks, we have this rheumatic fever, carditis symptoms, because we know it takes about 2 to 3 weeks to form a IgG antibody. So that is when this happens. And then after up to 15 years, okay, this is acute rheumatic fever can occur after 2 to 3 weeks, but up to after 15 years, what we get is the rheumatic heart disease. So we can use rheumatic fever and rheumatic heart disease interchangeably, but this is the disease course. You have acute rheumatic fever, which has these symptoms, arthralgia, chorea. We'll be discussing Jones criteria also at the end. So we have all these criteria. And we are going to have rheumatic heart disease after up to 15 years. What does rheumatic heart disease comprise of? It most common is it's going to involve the mitral valve. So mitral regurgitation is the most common. Otherwise, it can involve other valves also like aortic valve and also cause stenosis. So ultimately, this can lead to heart failure, arrhythmias, and thromboembolism. So this is the course of this disease. Already saw Schauff's body and anti-Schauff cells, which are caterpillar-like cells. A Schauff body we've already discussed. This is the pathognomic lesion of acute rheumatic fever. Usually, where is this seen? This is seen in the myocardium because we know it is in between 2 myocardial cells. So definitely seen in the myocardium. Composed of lymphocytes, primarily T lymphocytes, right? And then plasma cells, macrophages. Okay, and these macrophages are what are these anti-Schauff cells? In here it is not very evident, but yes, you can see an anti-Schauff cell here also. Here also you can see an anti-Schauff cell. Okay, so this is the zoomed out image, high power image of this macrophage, which resembles a caterpillar, ultimately called as the anti-Schauff cell. Sometimes you can see central fibrinoid necrosis also surrounded by immune cells and granulomatous inflammation. Definitely you can see. A Schauff body is also type of a granulomatous inflammation. What are the extra cardiac manifestations of rheumatic fever? You can have multiple extra cardiac manifestations because we know that this is a autoimmune disease. Autoimmune disease usually affects multiple organs. So we can see there is migratory polyarthritis. What is migratory polyarthritis? The arthritis kind of changes from one joint to another. So usually it's a large joint. Sometimes it involves the knee joint, sometimes it involves the ankle joint. So the pain just keeps on transferring. Then there is Sydenham's chorea. What is Sydenham's chorea? Chorea is, as per se, is known as involuntary movements. Okay, so this is a neurologic disorder. When this is involved with rheumatic fever, this is known as Sydenham's chorea, involuntary movements associated with rheumatic fever. And then we have erythema marginatum. This is a non-pruritic rash with erythematous borders. Subcutaneous nodules are also seen, which are firm, painless nodules over the bony prominences usually. And then we have elevated inflammatory markers. Okay, prolonged PER interval is an ECG finding which is seen in these conditions. There are few other markers which is ASO, increased ASO. ASO is anti-streptolysin O. So this is associated with infection of beta hemolytic streptococcus. So this is also increased in rheumatic fever. This image here is an example of erythema marginatum. Erythema marginatum. Why? Why is this known as erythema marginatum? Because the central area is kind of pale and the periphery is red in color. So there is erythema in the periphery, margins. So this is erythema marginatum, and this is the kind of rash which can be seen in rheumatic fever. This is a subcutaneous nodule which is seen in the elbow. Okay. So we have something which is known as a Jones criteria, which we have to remember for rheumatic fever. So I'm just making this O like a heart over here. This is an O. Okay, this is Jones. Jones criteria, you have joint. J you can remember for joint. Joint is nothing but migratory polyarthritis. Okay. And O, heart for carditis. We know the carditis is a pancarditis in rheumatic heart disease. And N is for nodules. Nodules in the subcutaneous region. Okay. E is for erythema marginatum. And S is for Sydenham chorea. Okay. So these are the major criteria of Jones. There are a few minor criteria of Jones also. Okay, what are the minor criteria? Minor criteria are increase in acute phase reactants, fever, okay, acute phase reactant protein. So these are all minor criteria. Leukocytosis, these are minor criteria. So these are very non-specific, can be associated with any infection. So hence these are classified as minor criteria. So for characterizing a lesion as rheumatic fever, you need to have two major criteria plus one minor criteria. Or you can have two minor criteria along with a, a definite streptococcal infection. You have to have a culture proven or a ASO titer which proves that there has been a previous streptococcal infection. Okay, to diagnose rheumatic fever. Okay, so that is it for rheumatic fever. We're going to discuss a few MCQs now. The first question, a 40-year-old woman has a history of recurrent sore throats, presented with fever and joint pain. She reveals multiple regurgitation also. So she is diagnosed with acute rheumatic fever. Which microscopic finding will be So this is the easiest question since we have discussed. We know that the answer is A. Shock bodies and anti-shock cells, which are pathognomic of rheumatic fever. Wavy fibers and hemorrhage. Wavy fibers we can see. Fibrin thrombin also we can see in rheumatic fever, but this is what is pathognomic. 60-year-old man presents with worsening dyspnea and fatigue. Echocardiography reveals thickened stenotic mitral valve leaflets with fish mouth appearance. The patient has a history of untreated streptococcal pharyngitis. So this is also a case of rheumatic fever, but now the answer you have to know the mechanism underlying this. So what is the mechanism in this case? Again, very easy. We know this is a molecular mimicry. Okay. Direct bacterial invasion of mitral valve leaflets is seen in infectious endocarditis. Hypertension-induced is hypertension-induced disease. Viral myocarditis, again, so none of these are answers. We know the answer is molecular mimicry. Okay, the next question. A 60-year-old man presents with worsening dyspnea and fatigue. Echocardiography reveals a fish mouth. I think that it's the same question, right? Okay, so that's it. We discuss some MCQs and we discuss rheumatic heart disease in detail. So we'll see in the next CVS 3 session with more previously asked questions from the same chapter. Thank you.